essentially our collaborations to ensure that we are actually creating impact on the ground. And so we're hoping over the next 90 minutes, again, probably a little bit of a whistle stop, but just to kind of hear from our partners, both past, present, and future, we anticipate looking at what are some of the key areas that we can start to perhaps strategically and intentionally work and collaborate over, and what are some of the strengths and what are some of the combined strengths that we can leverage off each other in order to ensure that we're actually creating impact. Now, the two areas that we've decided to focus on for this 90 minutes is really around the workforce and cancer research. We do know that, again, based on work from the Lancet Commission on cancer in sub-Saharan Africa, we do know that, of course, research is a critical pillar of any cancer control strategies. However, there was a real paucity of data or a data-driven policy informed by research in our region, and then the subsequent analysis of cancer research in the region done in collaboration with King's College London and AORTIC try to look at what is our research output. And we do see that there's we call them gaps, but I like to say opportunities. We do know that currently we are contributing only about 8% of the global biomedical research, which is specifically cancer research in Africa. So really an opportunity for us to think about how do we collectively and collaboratively try to improve that. And then looking at the focus in terms of looking at the research that we're doing versus the cancer burden, we see that if we look at cancers like breast and hematological cancers, we are seeing research and output that's commensurate with the disease burden. But we look at high burden diseases like esophageal cancers, cervical cancers, prostate and colorectal are still really showing a disparity, a disconnect between the amount of research and the cancer, the current burden. And then looking at the trends, we're seeing that in Africa, we know that quite despite, I would say, increasing efforts, we still have quite a number of our patients, getting diagnosed with advanced disease and frequently not completing their care. Really looking at, really suggesting that we should be doing more and looking at what is the supportive and palliative care. But again, our research focus is pretty much, you would see a global trend. There's no real difference between research priorities, whether it's in Latin America, in Africa, or across the globe, really suggesting that we're not the primary drivers of our research agenda. So the conversation is really around how we can work collaboratively to change that. And again, looking at the care delivery continuum, we do know that we do have the highest deficits in terms of the workforce, but how do we creatively work together? What are some of the innovation, strengths, and opportunities we can have to ensure that, irrespective of where our patients live in Africa or globally, they continue to have access to care? And that's really an intentional investment and development of the workforce. So here to start us off, without further ado, we would like to invite Dr. Kofi Nyarko, who is the NCD's team lead of the WHO Regional Office for Africa, who's going to give us a little bit about the 2025 report and key objectives in the lead up to 2030, but perhaps drilling down to what that means for Africa in terms of research and the workforce and why this is important. Welcome, Dr. Nyarko.
Thank you very much. Let me put on the slide. Please, can you see my slide?
Yes.
Okay, good. Thank you again. I'm Kofi Nyarko, the team lead for NCDs in WHO Africa region. Yes, I've been asked to talk about the NCD report and the key objectives leading up to 2030. So the presentation will look at mainly three things. Looking at the NCDs in Africa, we'll try to look at where we are, focusing on cancers, And now looking at the 2030 SDG goals, how are we poised to get there? What are the key objectives and what does it take for cancer to look at the key indicators and the milestones for cancer control? So this is generally for NCDs, which is looking at hypertension, which for Africa over the years, we have seen that we are not seeing much improvement, and it's for all NCDs. And the probability of dying and premature deaths too, we've seen that there's moderate decrease, not much. We want to now look at cancers from the IAP Global Can. We see that in terms of mortality, age standardized mortality rate, Africa is higher compared to the rest of the world in terms of breast and cervical cancer. We also see prostates also be an issue in Africa. So once we look at this, we realize that, sorry for the slides, we realize that we have a long way to go and to have a change in the picture that we are seeing in Africa. And we need to actually do something about it. So looking at how to get there in terms of the 2030, looking at the global action plan for NCDs and our regional frameworks, we have 6 main objectives, which we're going to look at what it's in for cancer for Africa. The first one, look at prioritizing NCD control. And this one, in terms of cancers, we have to raise awareness, advocacy at a higher level. And we think for cancer, it's happening. Integrate NCDs in the social and developmental agenda and strengthening international cooperation. And what do we do for cancer? Generally, we have NCD in general, but for most countries, as I'll show in the next slide, countries are now having specific cancer strategies, and some have gone down to develop even cervical cancer strategies because of the cervical cancer elimination strategy that WHO is championing. And just this week, we worked with experts to look at developing breast and cervical cancer strategies for Africa and integrating it at the PHC level here in WHO. So when you look at the next objective, it looks at strengthening national capacities and leadership. That is where we talk about budgetary allocations, taxations, making sure that our policies and our strategies are working, when assessing national capacities to know where the gaps are for us to move forward and develop and implement national multi-sectoral policies and plans. And with work from IEA and IAP, we have supported countries to develop NCCPs, and now countries are specifically developing cervical cancer plans, as I said earlier on. Looking at objective 3, looking forward, I think the key things here are to look at the tobacco and alcohol, and we've done a lot of work in using the FCTC and the Empower initiative. And if you look at Africa, I think we are doing well in tobacco, and we need to do more because these are one of the main drivers for cancers. And alcohol, using exercise tax and enacting and enforcing these laws, which are, especially in terms of exercise tax, there's more work that needs to be done. Now, when you come to strengthening and orienting health system to address NCDs, the key thing is looking at HPV vaccines. And now there's a drive to increase HPV vaccines. Currently, as we speak, 29 African countries have incorporated into their national immunization, the last country being Mali, and 4 countries have exceeded the 90% target for first dose. And we are doing well in this with, in collaboration with our partners and Gambia national governments. HPV DNA screening has been difficult. In terms of overall screening using pap smear and others, there are about 34 countries doing screening one way or the other, not systematic, but we have a long way to go in terms of using these HPV DNA-based screening, which is recommended. And for early diagnosis for all cancers, not only cervical cancer, breast cancer, all the major cancers, there's work that needs to be done within an integrated fashion, within a person-centered care, using a person-centered approach, so that once, for example, the woman goes in for cervical cancer screening, at that same time, it's used as a point of entry for integrated service delivery. And that is what WHO Afro we are looking at. Without integrated delivery and we continue to work in silos, we will not be able to achieve our targets. This is research, and we think is very important, and AORTIC has been helping with your members being in academia and research. So we recommend that we increase budgetary allocation for research in cancer. We need data for decision making. We strengthen human resource and institutional capacity and international corporations and local corporations so that we work with actual research institutions. And WHO is trying to identify institutions within the region where we'll be able to work with them to achieve this, because we have to collaborate with institutions so that we have tailored data for decision making. For example, when we look at breast cancer in Africa, the tumor biology seems different, even prostate cancer. So we need to find out what is happening in Africa for us to have tailored interventions for our people. And we need to continue to build research capacity in Africa. Monitoring, strengthening, and establishing a comprehensive NCD surveillance, including cancer registry, is also very key. And these are things that we still want to do and collaborate with our partners. Currently in the Africa region, we have few partners that we are working with in the area of childhood cancer with St. Jude. We are working on breast and cervical cancer with funding from Roche donation and few others. But there's still a huge gap that most countries are doing nothing. And we need support to get this done and collaborate and have maybe collaborate with other institutions to have funding to fill in the gaps. Some countries need little money to do things. For example, today, our regional director is in the Democratic Republic of Congo with the Prime Minister and First Lady trying to look at cervical cancer elimination strategies and what they can do to start with improving and having institutions, centers that they will be able to screen. So there's so much going on, but as you all know, funding is a challenge. Countries are committed and they want to do, so we have to support and help them. This is generally what is happening in our region. In terms of leadership and governance, as I said, low prioritization, poor coordination mechanism, health systems, they are working in silos. Now, cervical cancer is good to work with HIV programs so that we can integrate, because there are a lot of HIV issues, and people with HIV are 6 times at risk of developing cervical cancer. So this, we need to integrate. Few countries are doing it, Malawi, Kenya, Zimbabwe, with very good success. So we need to incorporate it in the health systems in Africa. And rapid urbanization, poor health seeking behavior, which is leading to low levels of awareness and late detection, as was said by the chair. We have to make sure that this changes. And how are we going to do this? Increasing political will, commitment, and prioritizing cancer at high-level meetings, like this forum, what we are doing. National government should know that it's an issue, so that it's prioritized, because the disease burden and in terms of funding for disease in Africa are not aligned, and we need to continue to advocate. We need to develop sustainable funding mechanisms for both domestic and donor support, take multi-sectoral approach in addressing the determinants, especially commercial determinants of health, is very important. And enhance screening and access to care, using a person-centered care from the community level, and developing innovative approaches. For example, use of technology, the use of AI. There are so many things that digital solutions, mobile health can help us achieve to break the physical barriers, especially in screening. And few countries have started this. I think Zambia, Zimbabwe, Senegal. So we need to learn lessons and increase coverage in the region. And data for decision making. Integrate several cancer indicators into existing systems and make sure that we utilize the data, tailor-made data for Africa, so that we can have tailored solutions for care. So, with AORTIC, we have a lot of opportunities to work together, especially in the area of research and capacity building. We have limited capacity across the region. We need to train more people for service delivery and also to do research that will give us information for us to get tailored solutions for cancer control in Africa. So this is our priority as we go ahead on the road to 2030 so that we'll be able to achieve our SDGs. So in summary, this is what I have. Thank you very much. I'm available for any questions. Thank you.
Thank you. Thank you so much, Dr. Nyarko, for that overview and really, as you said, highlighting some of the key areas and priorities that we need to have to move things forward. I think we're happy to start, from an AORTIC perspective, to start to work more intentionally with yourself and other emerging partners, really trying to answer this question. I think one of the key areas that you had mentioned is really that working in silos. And I think it's also taken us a bit of time to sort of shift from we're also guilty of that, only seeing cancer only, maybe somebody seeing communicable diseases, but even just sort of embracing that entire continuum. I think maybe a quick reflection is, I think one of the comments raised in the audience is, are NCDs actually on the continental agenda? And if not, how do we perhaps amplify the voice around the need for awareness and intentional investment in non-communicable diseases? Thank you.
Yes, can you repeat the first part? You talked about is NCDs seen as a continental agenda or global agenda. Can you repeat that part?
Yeah, no, I was just saying you had given us a great, an excellent overview of where the priorities are. And you had mentioned some of the challenges we're working in silos. And so one of the questions that we had, one of the questions raised is really one of the things that has been traditional is we've been sort of breaking down all these little diseases into little diseases. We're looking at diseases, not at systems. And so it was just to really reflect and say, do we feel that the NCD agenda is part of the African agenda? And if it isn't, how do we amplify that? And even if it is, how do we continue to expound on that from a collaborative standpoint? Thanks.
Okay, thank you very much. So now NCD is a top priority for WHO Africa region. And we had several meetings, and our strategy is to use an integrated person-centered approach, because we have reviewed the work we've done over the last 3 decades. And we realize that if we don't change our strategy, and if you look at the Global Action Plan for NCDs in 2011, I indicated that we should use integrated person-centered care, but we don't see it in operation. So now our priority is to ensure that NCDs and other diseases that can be integrated should be integrated. 2 weeks ago, we had a meeting of the World Bank, the Global Fund, and a few other stakeholders on NCDs integrating with HIV and others in Uganda. So right now, that is the way we want to go. And this year, we were going to have a framework developed on integrated care using NCDs as an entry point to ensure that the same patient who has cervical cancer will also be screened for breast cancer. Or the same patient who goes to a clinic for diabetes will also be screened for cervical cancer. We had a meeting and one delegate from Angola said there was a patient who was a diabetic and went to the clinic every 3 months for review in Angola for 14 years. And one day the patient told the doctor he was having vaginal discharge. They checked and it was stage 4 cervical cancer. And this patient had been going to hospital for 14 years non-stop every 3 months. But they were only looking at diabetes and refilling the diabetic drug. So now we want to have an integrated approach, especially in Africa, where we don't have the human resource and we want to train at the PHC primary care level using task shifting, for example, so that when somebody comes, there will be a protocol on the basic things to check and referral pathways and referral mechanisms to go and see the specialist so that there are no missed opportunities. So there's our priority for the region.
Yeah. Thanks, Dr. Nyarko. And I think you've raised a really important point around making sure that it's a patient-centered approach. I think really some of the concerns are when we reflect on the workforce, the challenges of integration and how do we ensure that we're strengthening systems. And so perhaps that's a nice segue into the next talk by Dr. Adelad Kakunze, who's going to spend some time talking to us about the African CDC and how it's partnering to strengthen health systems to address not just non-communicable diseases, but injuries and mental health in Africa. Dr. Adelad, I don't know if you are able to present live.
Yes, thank you. Thank you so much, Prof. Miriam. Thank you, first of all, for the invitation. It's a pleasure to be part of this meeting. So, as you rightly say, I will really ride on what my colleague from WHO was talking on the need really to ensure integrated health system, not only for one diseases, because we cannot afford, as he beautifully said, having a siloed clinics for diabetes, for cardiovascular, for cancer. So we need to see how to integrate it. So for me, I will really try to quickly share Africa CDC plan, and I believe for those who may heard about Africa CDC for the first time, I will go through like quick background on what is Africa CDC and how we started working on this very important challenges and where we are. So a bit of history. The Africa Center for Disease Control and Prevention was first mentioned during the extraordinary summit on HIV, TB, and malaria. And at that time, the head of states were looking at establishing an agency that will help to conduct life-saving research on priority health problem in Africa and to serve as a platform to share knowledge and build capacity in responding to public health emergency and threat. And they were right because the next year in 2014, the continent faced the most devastating outbreak, the Ebola outbreak in West Africa, and this also put some urgency on operationalizing the Africa Center for Disease Control and Prevention. And you can see two pictures. The first one is at the launch with the former African Union chairperson, Madame Zuma, and the chair of the union at that time, His Excellency President of Guinea. And if you look very well, you will see also a familiar face, the DG now of WHO, who was then the Minister of Foreign Affairs in Ethiopia. And now Africa CDC has evolved into an autonomous agency of the African Union that's has the legal, institutional, and operational autonomy to support our member state and can make decisions in case there's a need for urgent response of deployment of resources to fight diseases. And here we're talking about high burden diseases like non-communicable disease, highlighting cancer, but also injuries and mental health, and is more accountable for the decision and policy being made to address the gaps in Africa health system. And when Africa CDC was established in 2017, there was no program or division to work on those high burden diseases, including communicable and non-communicable diseases. And we came into existence in 2020, in the middle of COVID-19, and it was really an opportunity to build on the Africa CDC and the whole continent collective response to COVID-19 to develop now a continental strategy on non-communicable disease, injuries, and mental health. And you could see now that it's now a fully fledged division now moving into a center that is focusing on non-communicable disease, injuries, and mental health, infectious diseases, the endemic diseases, HIV, TB, malaria, and neglected tropical diseases, the community health system and reproductive health, and infection prevention and control. And this division is dedicated to strengthen Africa health system for the prevention and control of communicable and non-communicable disease to achieve positive health outcome. And when we talk about integration, I think this is where it need to start. It's true that we have different programs, but we are using the same public health approach, the same tool to address those diseases, and that's why having a continental strategy on that is important to be able to leverage on that. So the first Africa CDC strategic plan did not talk about NCD injuries or mental health, but what we have done to develop a continental strategy on that have ensured that in the second now Africa CDC strategic plan, the first priority, the first pillar is on strengthening integrated health system to prevent and control high burden diseases. And the priorities for NCD are well captured in this first pillar. So in doing this, we're to make sure that we generate evidence and share those. There are some paper that you can find in peer-reviewed journals on the process, on the what we have done so far in this. So let me quickly talk, because you can have these documents available on our website on the strategic priorities now for NCD, injuries, and mental health, and try to highlight what we are doing, particularly for cancer prevention and control. So the first objective is to support countries to enhance the capacity to develop, integrate, and implement the national and supranational framework and policy for the prevention and control of NCD, injuries, and mental health. And here, the flagship is to support countries on integrating NCD injuries and mental health into primary and secondary healthcare. This year, we, for example, have supported the Gambia to develop and cost the national cancer control strategies, and see how to leverage on the overall NCD program. And we've been doing this for other countries on mental health and NCD broadly. The second objective is really advocating for political commitment. Here we are looking at not only increasing political commitment, but how do we ensure that this is translated into more resources, into more action. And here we are leveraging on the fact that the African CDC is an African Union agency where we have access to head of states to see how to escalate this to the head of states, because at the end of the day, if we don't have it's not coming from them. It will be difficult, to really make progress. And those are the things we are doing to have a champion for NCD that will really position this at the highest level of decision making, and also having declaration, because it's important to always have this highest political buy-in to be able to coordinate and focus action on the ground. The third objective, which is really also another area where Africa CDC and African Union have comparative advantage, is allowing member states, regional economic community, and partners to establish and strengthen and coordinate the multi-sector action on NCD injuries and mental health. For example, we have established last year an African Union multi-sector task force, and to lead and coordinate action across sectors. And I think this is the first time this is being done, where we bring all the African Union organ, the Africa Continental Free Trade Area, the African Union Development Agency, the former NEPAD, the all the commission responsible for trade, for industry, for transport, for agriculture, for health, together to lead and coordinate action across sectors. And it's something that we are really pushing and putting forward, even for the UN, the upcoming UN high-level meeting, because this is really important. And the task force established one of the priorities is to address commercial determinants of health that have a significant impact when it comes to cancer prevention and control. The fourth objective is workforce, and I believe this is the main topic of this session, in looking at how to build the required workforce. Because when we are talking about integrating, yes, we need to give guidance on how to go about this, but who is going to do it? And I liked my colleague Kofi, who highlighted the importance of task shifting, task sharing, but also there's an opportunity to leverage on existing a program that have demonstrated impact. The Field Epidemiology Training Program has really supported, helped countries to have a workforce to respond to outbreak. We can repurpose or develop new program building on this that will help us to have the critical mass of workforce to support this integration, to enhance surveillance at the national, subnational level. And we are working with partners really on this. We have started with the mental health, and soon with a regional workforce program targeting to African region. So the fourth objective is on funding and sustainable funding. And for example, one success that we are proud was to ensure that we have NCD program and ensure that we are receiving at the African Union funding from member states. It demonstrates also that member states are serious about this, and that's something that we always put forward as a good example. But we want to go beyond and ensure that we have enough resources. We are developing funding, like regional funding, African fund, to for this, and this is something that we are really pushing at the Africa CDC and African Union level. The last objective is on ensuring that we have the right technology, medicine, and diagnostics that is required for NCD injuries and mental health by supporting the local manufacturing and food procurement of this product. And this is a flagship program of Africa CDC to ensure that we have the required product technology, not the old technology, but the latest, to ensure that also our population can afford those. And one of the things that we are putting is the pool procurement with the now the African pool procurement mechanism that is being established. where we are really position NCD products as a priority product under this mechanism, but also pushing the local manufacturing agenda. So I will quickly talk about the key activities. I've mentioned about funding. With this, we were able to mobilize real funding externally and internally for the program, the multi-sector coordination I mentioned, the task force that was established, and that we really want to leverage on to ensure that we bring the other sectors, because clearly we know that 70% of the risk factor and the 10 social determinants are beyond health, and this is not a issue of health only. And having this at the African Union level, at the continental level, can really help us to go a long way in supporting our member states. On surveillance, we have developed guidance, and we are now looking at how helping country to develop key indicators, and also at the continental level, establishing a dashboard that will help to do a country comparability and region comparability. Workforce, I've mentioned. This is an area where we started early on, bringing together NCD leads in member states, and forming what we call a network to advance peer review, learning, and support on NCD injuries and mental health, and of course the flagship program on mental health that we are now looking at how to expand it to to NCD. Well, this is for mental health, the integration of mental health and psychosocial support into emergency preparedness and response, and ensuring that we have such capacity with the African Union, Africa CDC standby forces, if I can call it, the African Volunteer Health Corps, support country on mental health registration, and of course conducting advocacy, etc. So those are some of the what I've mentioning. This picture is interesting because you could see some of the African experts that we have on NCD injuries and mental health, and we are working closely with this powerful team to ensure that they support and guide the implementation. I've talked about the task force. This is the document on strengthening the NCD surveillance system in countries, which is available on our website. You can download a copy. Of course, the mental health leadership program with a focus on the developing on establishing a field epidemiology training program in mental health, and that's what we are also doing for NCD very soon, but also ensuring that we are also embedding mental health in a different flagship workforce program at Africa CDC. We have the prestigious Kofi Annan Global Health Leadership Program, where we were able to start a mental health cohort, and this is interesting. Most like the NCD and mental health people, we will not see prestigious program like this. And when we were starting this, we were thinking, can we have a NCD or mental health a program that we can establish? Because we were looking, you will find HIV. There's a prestigious program going for years. TB, the same. Maternal health, the same. But we did not have NCD. But we say, creating a new one will again not help us to achieve what we want, because we like to talk among ourselves. Let's open up and embed with those existing program, and be able to socialize NCD and mental health with the HIV expert, TB expert, NTD expert, and ensuring that we catalyze on this cross collaboration, and of course engagement with civil society and lived experience, very important in everything we are doing. So this is some of the support to countries. The first picture in Tanzania, one of the countries that have really made progress on integrating, for example, TB and diabetes, HIV and diabetes, and country that we are looking at and supporting other member states. This is where we did an activity back in September 2022, bringing 30 countries to see how the country have been able to do it at different level, from the primary to a tertiary level. Morocco on the specialized cancer program. Here there's a field visit at the National Cancer Institute, and this is very important also because we are looking at how to strengthen South-South cooperation in terms of specialty training, in terms of exchange. And we are looking at countries that have really made progress to see how to make those hub for innovation and how they can support other countries. And here we had around 20 countries, mostly Francophone, to take part in this. Mentioned about MHPSS integration, the mental health and advocacy. And yeah, in conclusion, the COVID-19 pandemic has showed that the continental action on NCD injuries and mental health is timely and urgent. And it have taught us that investment in regional cooperation, coordination, collaboration, and communication should be leveraged and adapted to respond to the increasing NCD injuries and mental health burden. And the continental now response to NCD injuries and mental health could build on this structure, particularly in integrating into strengthen public health institution at the continental and national level, scale up capacity building for workforce, build on established platform for pool procurement and local manufacturing, and ensuring access to sustainable funding and foster better partnership across sector to benefit NCD injuries and mental health. So that's my last slide. Thank you so much, and I will look forward to any question, comments. Thank you. Over to you, Prof. Miriam.
Thanks so much, Dr. Adelad. I think we'll probably ask you to have some reflections, and we're closing. But there's been, I'm sure you've been following the comments. There's quite a number of interesting questions and comments. One around the need again to have regular meetings and really cross-talk between whether it's WHO, Africa, CDC, AORTIC. I think we're pleased that we were recently in Addis, and thank you for hosting us, and looking at really developing a consolidated work plan in the next coming year to look at how we answer some of these key questions, whether it's around access, whether it's around political or high-level advocacy. And you did, of course, mention the high-level meeting that's coming up next year. So it's really an opportunity for us to think through what are some of the concrete steps that we can use to amplify some of the key priorities that we've defined. But I think in terms of trying to answer some of the common questions that we have sort of raised, one of the issues is around, and our first panel discussion is looking at how can we galvanize African cancer research and building on the strengths of international partnerships, and what will this take? And we're pleased to have our VP North America, Dr. Abiola Ibrahim, who's going to lead this discussion and try to tease out maybe some of what are the key areas that we should be thinking through, even as we start to think about how to expand research in Africa and research that actually impacts our patients, in keeping with the integration and patient-centric approaches. Welcome, Dr. Ibrahim.
Thank you, Miriam. Thank you for the introduction. Thank you for featuring the AORTIC statement on African cancer research. So right now we're going to be moving gear a little bit to talk about what we are doing as far as cancer research from AORTIC's perspective. In the last decade, we have done a lot of training of African investigators on the continent, and specifically, we have done a lot of training with regards to clinical trials. And what we do see in all those recent FDA-approved clinical trials in the last decade has shown a dismal representation of African descent patients. We actually do have a New England Journal of Medicine, a study on the PIK3CA mutation showed only one patient that was Black was on that trial of 370 patients. That's ridiculous. And it's not only in breast cancer. We see this in prostate cancer. We see this all around the cancer continuum. So this is a problem whereby we see in real time that this is not just an African problem, right? Now we talk about all this research, all these interventions that we are doing from prevention, and our patients, when they do show up, what treatments do we have? What do we have to offer them? Are we even doing what we call the evidence-based medicine? And all these patients, when we are not involving them in trials, in research, it's going to affect our patient on the long run. So today we have panelists. My panelists is very powerful people who will be talking about this problem, where we'll be talking about what will it take for us to actually improve cancer research, what will it take for us to build on the strength of our international partnership. So the first person on our panel is Professor Robert Lewis, who is also the chair of our AORTIC Research Committee. And we also have Professor Elizabeth Jaffe, who is a partner from AACR, and she's an international leader in the development of immune-based therapies. And we also have Professor Michael Mochiro, who is a surgical endoscopist from Kenya, and he's the current chair of the College of Surgeons of East, Central, and South Africa. And he also chairs Education, Research, and Scientific Committee. And we have, I think, hopefully, Professor Funmiyola Pade is going to join us today. She's actually tied up in clinic, and at some point, I hope she joins. All right, so I will open the floor with Professor Lewis, who chairs our research committee. And the question I have for you is that from your own perspective, I know you've chaired a lot of others trainings of African investigators on research, and I know you do a lot of research yourself on the continent. And the question I have is that with all the trainings of African investigators, where do we go from here? Apart from training, right? You know, we get overtrained in Africa. Where do we go from here?
That's great. Thanks very much, Dr. Ibrahim. And thanks to AORTIC for the opportunity to have this conversation. I think at this forum, it's really important. I think the key questions about where do we go from here relate to a couple of different issues. I think a core one is the area of implementation. So there's, first of all, what we know already that we know is common to all of cancer broadly across the globe, that we need to figure out what are the key challenges to implementation in Africa, and how do we garner the resources needed? How do we do the research so that we can identify the key factors and the key determinants of what I think of as the last mile? How do we get it to people who are living in rural areas, who are living in villages in Africa? How do we actually create a sustainable path so that they can receive the benefits of things that we have discussed already, such as, for example, HPV vaccination? So I think there's a key importance to implementing the things we know already. And then there's the importance of trying to understand what is unique about Africa that we do not understand. So for example, we have a major problem if we think about what is typically the second most common cause of death for cancer in men, which is liver cancer, and usually the fourth or fifth most common cause of death in women. We see liver cancer in sub-Saharan Africa at a very early age of onset, typically people in their 40s. The next closest region would be in Asia, where they're seeing people in their mid-50s. So we have about a 10-year earliest age of onset in Africa. It's important that we understand why, And it's important that we understand what we need to do in Africa to make a difference in Africa. Because, for example, we know that the viral genotypes are different in Africa from what we see in Asia. But the recommendations for treatment are typically based on data from Asia, because that's where the data is. So it's really important that we focus in on Africa, on the African condition, on the African epidemiology of these diseases. Does it mean that people that would not normally be treated in Asia should be treated in Africa? And should we be treating individuals earlier? Would this make a difference? And there are huge gaps in our knowledge that we need to really fill. And so I think that's the second issue, is really the unique things about, and there's multiple cancers here. I mean, we know the same thing is true about breast cancer in Africa. It's occurring at an earlier age than in other continents. What is it that we need to do to better understand these diseases and develop then the guidelines for effective early diagnosis and treatment? And then there's the research that's needed to do translation. And I think about translation from the perspective here of early detection. One of the things we talked about earlier is the fact that the vast majority of our patients with cancer in Africa are presenting with advanced stage disease, where palliation is the only thing we can do for them. It's really important that we transform this paradigm. And what we are seeing in certain areas is that I work in the liver cancer area, so you'll excuse me if I use liver cancer the example. But if you go to hospitals in Africa and you set up a hepatitis clinic, in the context of a hepatitis clinic, you begin to screen people for cancer. What we saw at 3 teaching hospitals in Ghana was we saw a shift from 95% of people presenting with advanced disease to 30% of people presenting with early and intermediate stage disease within the course of 2 years. So there's clearly things that we can do, change that we can make, that allows us to bring people to recognize cancer in patients at earlier stages. And when we do this, if we then focus the treatments on things like surgical resection, which can do very effectively for patients with early stage disease, treating early stage disease is much more effective, and treating early stage disease actually is often much less expensive than trying to treat advanced stage disease. And so I think there's things that we can do from a practical implementation, but also from a practical research perspective. And I think it's important that we have, for example, people that are interested in translational research who are looking to develop low-cost early diagnostics for cancer in Africa. We know there are many companies developing early diagnosis for cancer for industrial countries at costs that people in Africa could never afford. So it's really important that we bring the African workforce focused on how do we develop diagnostics that are really accessible to the populations that we are dealing with, that can be supported by the health systems that we are building. So I think those are broadly some of the key issues. I know in the interest of time, I'll stop there, and perhaps we can have some additional discussion. It's been really encouraging to see the role of outside organizations. There's a fair bit of support, for example, from the U.S. National Cancer Institute for partnerships of institutions with Africa. The same is true from the support from the UK and the EU. And I think we need to continue to build on these partnerships as well, and figure out the ways that we can work better together. But again, the focus, I think, has to be on solutions that we can actually implement in Africa. Thanks very much.
Right. So you just gave us you just answered my next question, which was I wanted to ask you how we're going to ensure relevant research in Africa, which you already talked about. So I'm just going to move this to Professor Elizabeth Jaffe, who is a representative of AACR today on this panel. And the question I have for you is, AORTIC and AACR, we both share a passion for clinical trials. And then what will it take for us to establish a collaboration, a true collaboration and partnership with an African clinical trial network? What will it take for us to be part of this industry conducted trials? Because the truth of the matter is that the industries are the ones driving these trials, and they go to all these networks, the SWOG and what have you, the Alliance group, to be able to conduct these trials. And I think that if we start having that partnership, with African investigators, I think we'll be able to move the needle forward. So from your own opinion or your perspective, what will it take for us to get a seat at the table?
Yes, that's a really important question. And as I was listening to Dr. Roberts, who presented a lot of the challenges, but also priorities, I was thinking industry needs to be a partner at the table. I think that what we're trying to do with AACR and the grant funding, although I wish we had a lot more grant funding to support, is to help to build the infrastructure at centers that will make these centers more appealing to industry, because they need to make sure that there are structures to really do the research. I think we also need to present opportunities that would really, be a collaboration with industry. So what diseases are they interested in? What diseases are the people in Africa? And of course, Africa's a big place, and this may be different depending on the countries. But I think the major concern from industry would be having that infrastructure where they know they can get the right data collected in the right time. Patients will be enrolled, they'll be trained, teams on the ground that can work with these industrial partners. And I think this is part of what we need to do as organizations in the United States and Europe and in Africa, to work together to help build those structures, make them stronger to recruit industry.
Thank you for that. All I would like to point out is that at AORTIC, we've been doing a lot of training. We've been doing a lot of site visibility mapping. We have data that has been collected a couple of years ago, and we have ongoing data that we are hoping to collect with CROs, because what we have recognized is maybe if we get the industry at the table at the beginning, at the onset when we are collecting our data, right, then hopefully they will be able to partner with us on that level. But we need your partnership to kind of steer them into the right direction to actually come here and conduct trials, because when infectious disease trials are being done, right, I'm not sure there's a problem. There's no pushback. Everyone wants to do trials when it's COVID or Ebola, and then when it's cancer, there's a problem. So I'm going to move the discussion a little bit. Professor Michael, you're a surgeon. And the question I have for you is that, what is that thing that will mobilize research in cancer surgery?
Yeah, thank you. And it's been a pleasure to listen to all of the areas that we have room to actually improve outcomes and training in the continent is leveraging on the networks that we have. So for example, I'm part of the College of Surgeons of East Central and Southern Africa, COSEXA. And one of the things we did was to do training in the hospitals that exist. And so you identify the resource, you work with the local governments, you identify the trainers. But then, of course, if you start, you might have a small pool. But as one generation of trainees finishes, then you have more and more specialists who are available as trainers. The other point I wanted to raise, which is cross-cutting, as you train the surgeons, you need the nurses, you need the anesthetists, and you've seen there's been a growth in the colleges in the continent doing the different specialties. And the other bit is, how do we identify people who are talented in research at an early stage? And then how do we get practicing surgeons to begin asking the questions, I'm doing all of these procedures on cancer, what are my outcomes? What impact is it making? Is there a disease specific, for esophageal cancer, which is what I've been working on for a long time? We keep asking the question, is the tumor biology different? Are we seeing a different disease entity in Kenya, Malawi, Tanzania, Uganda. So I would say AORTIC, in partnership with ACR and the other bodies, NCI in the US, have done a good job in training early scientists and clinicians. I think there's more work to do in this space, grantsmanship, publications. Dr. Roberts was talking about research. How do we get the research that we do visible out there as a surgeon? And then the last bit, as I conclude, is if you are beginning to do the specialized surgeries, you need a specialized unit to support that. And so we need the government support to be able to do this. I go back to esophagus again. If you're doing the complex surgeries, you need an ICU stay. And so this kind of setups will need a lot of investment, both in training and in funding. But ultimately, we are making progress. I think over the last 10 years, you can see, Dr. Mutebi talked about disparities in research, and esophagus is one of them. And we've come together as consortium through the Africa consortium to see how we can improve that specifically. And currently, we're working on a large training grant for training in surgery, nursing, endoscopy, and oncology. I'll allow us to move on. Thank you.
Right. So one other question that actually came to mind, and I think it's a problem in North America, is that we have all this high specialized research, but then implementing it in an healthcare system, it takes sometimes years or decades for that to happen. Then implementing it in the community hospitals that are not research driven, it's even longer, right? And I would ask Professor Elizabeth this question, because I know a lot of research has been ongoing in the implementation science field to be able to shorten evidence-based treatment or life-changing therapies, to shorten that time for it to get to the community or everyone. So what would be your suggestion? I mean, because at this point, we have to get lessons learned from North America, from the Western world, and we have to be able to learn to chew gum at the same and run at the same time. So what would be your suggestion as far as we are trying to pump ourselves up in the research field, as we're trying to improve our skill set in clinical trials? But what would be your suggestion for us to, at the same time, start thinking, how do we get in the implementation science part of it?
I'm sorry, are you asking me that question? So you're right, it is a huge challenge. We have a lot of funding and money put into our healthcare system, and it's not getting to the people we need it to get to. Education is a huge issue. Communication is a huge issue. I mean, I don't have to tell you about the political issues around COVID. Well, even around the human papillomavirus vaccine, we have those political issues. I mean, nobody should die of cervical cancer anymore, right? We have a treatment. It's not even that expensive. And even in the US, we can't get it to the communities we need to get it to. So we talk a lot about, not only, the science of implementation. There's a lot of science, but it comes down to education. It comes down to education in middle school, in high school, young people. We have to get young people understanding. We don't communicate well in the United States. We talk about going into communities and going to community centers and churches. Young people aren't there. That's not how you communicate with young people. So I think communication is a problem. We also talk about social determinants of health. Cancer does not come up in our communities as a high issue. It's food insecurity, it's housing, it's all the other things you think about. And we have to solve those problems. I'm sure that's a worldwide problem, not just a United States problem. The difference is we have lots of money and we have these disparities. We have the wealthy people and then we have the people who don't have much. And so it's really a complex answer, because the implementation science tells us what to do. We have the science, but it's a real challenge.
Thank you. It is also a challenge in the African continent too. And I think the last question I would really want to ask Professor Lois and Professor Michael, if you would respond to this last question, is you work on the continent heavily, and you have a huge presence on the continent, and you are big on education and training, especially in the research field. But the problem with, say, in Africa is you train people, and then there's a huge brain drain, because they cannot stay back and with almost nothing to work, and then we lose them to the Western world. So what are your thoughts about how do we keep our brain? How do we keep our resources, our human resources? We can have all this training, we can have all those infrastructures, but if there are no human resources, if there's no workforce to be able to do it, we are going to go back to square one. What are your thought process on being able to keep our resources that we are going to be training, that has been trained on the continent? So I'll go with Professor Lawis, if you can start, please.
Yes, well, as someone who trained originally in West Africa and then lives in North America, that's a really good question for me, I think. But I think particularly what it always brings me to is the idea of a brain circulation. We talk a lot about brain drain. What many of us don't recognize is that in the post-World War II era, early 1960s, the big problem in Taiwan was that all of the young engineers were leaving and going to a place called Silicon Valley. By the mid-70s and into the 80s, Taiwan was producing more semiconductors than the United States. So I think part of it is that we have to challenge our governments to figure out ways to make that transition back feasible. At the same time, we also have to challenge people who are in the diaspora, because they can have a huge impact by making time to go back to Africa. And I think that what we have seen in a number of cases is that there are organizations that are really wanting to facilitate this and that are able to facilitate this. And I think a lot of the funding agencies are particularly interested in building collaborative relationships between organizations or academic centers in the US, in Europe, in Asia, and those in Africa. So I think we can leverage that interest to really focus on ways in which we can make an impact in Africa, even from a base outside Africa. But I think, again, as Dr. I'll maybe stop there. Dr. Machiro, I think, can pick it up, because I think he's been really focused on the training in Africa as well. And I'll stop there.
Mm-hmm. Yeah. Thank you, Prof. Lewis. I actually agree with you. There's so two concepts. One is we have to move the skill set in our continent to be able to offer world-class care. It doesn't matter which part of the continent you're on, you should be able to get, the most recent care. Now, we all know there's gaps to that. So I'll give you an example of from the surgical side first, and then the cancer side. So as COSEXA, one of the things that we did was, as I said, to work with the hospitals where they are. And you actually have an interesting paper that we published a few years back where we saw our retention rate increased to 95%. And the reason was the trainees were training where they lived. So there was more motivation to stay there once you are done with your training, because you have your home, your family. If you have a farm like me or a cow or goat, you're more likely to stay in your locale. Secondly, many of the graduates wanted, to specialize in surgical oncology or cardiothoracic, breast surgery. And so creating those opportunities. And one of the things we did was to talk to our partner surgeons in the US, in Australia, in the UK, to allow these graduates to go and then come back and offer the care. So now we are working on having the subspecialty training available in the region. And that's been the key last 3-4 years. We've been actively working on that, making the partnerships, sending some key champions for training and having them come back. And then my last point is in the cancer space, I think that's where it gets a little bit more complicated, because if you are highly trained and you don't have, the equipment to use, you're likely to be poached to go somewhere where you can use your skills. And this is where the government come in again. Mutebi is here. When you go for these high-level meetings and you're trying to tell them, hey, we need this in this hospital. And they're like, yeah, but we have X and Y we want to buy. And I think industry, as has been pointed out, have played a big role in providing some of the equipment and, equipping some hospitals. But I would say, as I conclude, we are actually making progress. And I think there's enough examples in the continent now. We've just done a second paper looking at this same question, and the findings are almost the same. More of our graduates are now staying because they have the facilities and the access to different things that they would need at a personal level. So there's two different levels to this. But I thank you for, this has actually been a very good discussion. Thank you, and over.
Thank you for that. This is a very good segue for our new, the next incoming panelist group being led by Professor Alatishe, where they'll be talking about the steps to build and retain strong cancer workforce. All we just did was, how do we retain the cancer training and research training in Africa? And they'll be talking more about this. Thank you very much to our panelists, and thank you to our listeners. Over to you, Professor Alatishe.
Thank you, Abiola. I hope you can hear me clearly.
Can.
Yeah. The issue of retainership of our workforce is a big issue, and it's something that we should always discuss at a big forum like this. And we are lucky to have an interesting panel and excellent specialists that can help us look into this. I won't take time to introduce each of them because each of them have a very heavy CV that it will take 20 minutes to introduce each, but I will just briefly introduce them and we'll go to the discussion so that we can maximize this time. Our first panel is Julie Grallo. Most of us know Julie Grallo is a Chief Medical Officer and Executive Vice President of ASCO. She was a breast oncologist before she moved to ASCO, and she has led a lot of consortium that have provided some of the evidence that we are using in the management of breast cancer and some other cancer till date. The second panelist is Dr. Nazima Dazi. Dr. Nazima Dazi is a leading expert in clinical oncologist and currently serving as the head of clinical oncology department at Ocean Road Cancer Institute, Dar es Salaam, Tanzania, and Mobile University of Health and Allied Sciences. Is based in Tanzania, and she's a leader and a mentor in oncology. While the third speaker is my friend, Dr. Susan Sitonje Nsadabe. We've been involved in training together, and is a prominent figure in the field of oncology and particularly known as a cancer researcher and healthcare in Zambia. She's a clinical and radiation oncologist, and she will be part of this panel. So we all know that a number of experts, the best and brightest, are staying in the African shore, and that has actually led to a lot of problems in improving, in ensuring we have proper care for our patients. So let me start from with Nazima. Nazima, you've seen the menace of drifts of our brightest and the best in Africa, leaving the shore of Africa. How do you think this drifts, this brain drain, affect the integrative care for cancer patients? And what have you done in your little capacity to mitigate this? Nazima, please.
Thank you very much, Professor Alatishe. So that's a very relevant question, especially in our setting where our limited resources are used to invest in the training of our workforce. And then we have these very bright opportunities coming up for our youngly graduated cancer specialists who are eventually tempted to move away and not come back. I feel we can look at this problem from two perspectives. One is for those of our young cancer graduates or specialists who go abroad for training. Many of them, I think nowadays, we feel that there is a lot of goodwill on the part of partners and collaborators who are supporting some of these institutions in their training. And what we found has worked on our side is having some kind of an agreement with these institutions so that when these specialists come back, especially if they are focusing in a very niche area or specialty, which we realize that they may not have access or they may not have the infrastructure or the environment to practice in. Giving them the opportunity to really build capacity locally and build infrastructure locally really helps them to motivate them to stay. For instance, I'll give an example of we had a young PhD candidate who went to the US for training in viral oncology. Now, this was a very niche area for Tanzania, but the agreement with the institution was that when the graduate comes back, there was funding and there was development of infrastructure locally. So to develop the labs and the local capacity at the institute to support the continued research work of this graduate. And it was a good success story because not only did the institute benefit from the development and the infrastructure, but the graduate was eventually able to attract more grants and more funding and several other PhD candidates that grew out of this program. So that is one example of an option that may work. But for those of our candidates who train locally, I think once we have the luxury of having a bigger workforce in the cancer area, and we can sort of subspecialize, it may be worthwhile considering giving them opportunities to do other things. If not all of them, maybe not all of them are focusing on the clinical areas. We've had specialists who would prefer to work in the academics or maybe in research. Some of them want to go for advocacy, etc. So I think building that kind of opportunities and capacity for them would help to retain them as well. And finally, if we're talking about our regional opportunities, I think as AORTIC and as our realization where we can work across the region that realization is very strong. From the education perspective, we have realized that there is a lot of disparity in terms of our educational opportunities and trainings. And I know AORTIC is, through the research and training committee, is also working hard to try and make sure that we have additional courses in which we have graduates at different levels coming to an area where they can easily cross across the country, across the region, and work across the region rather than having to move out of Africa. So doing that and then leveraging our advocacy and reaching out to governments to making sure that we have good opportunities to retrain the workforce may be an additional factor that could help. Thank you.
Yeah, thank you, Nazima. Let me go to Julie. Julie, we know HASCO has been a long-term partner of AORTIC. HASCO has been a friend, not to AORTIC alone, but to Africa. How have you, as an individual, because you're an academic and you're an achiever on your own, and then the ASCO that you lead, work to ensure that many Africans, the best and our brightest, are retained to serve Native African? And where should ASCO and AORTIC focus on to ensure that we build cancer team that can help, that is needed urgently on our continent? Julie, please.
Thanks for that question. I think in our memorandum of understanding with AORTIC, a large part of that is focused on joint training and education, strong in clinical trials, but also beyond that. Our ASCO strategic plan has 3 pillars: access, profession, and knowledge. So we're talking about that middle pillar there, the profession piece. We have issued a global curriculum for medical oncology. ASCO and ESMO jointly developed it. And our Sub-Saharan Africa Regional Council has expressed a lot of interest in adapting that global curriculum to the African context. And we'd love to partner with AORTIC in that as well. So that's one piece, that's the training piece of it. With respect to the retention piece, Nazima addressed it really well. It is complicated, especially when you've gone abroad for training, to think about coming back. If you can't practice the high quality of care, you don't have the resources back home again that you know improve outcomes. And I've heard Princess Dina Merritt of Jordan, when she talked about how did she bring back some of the Jordan doctors who, when she couldn't compete for salary, there was no way they could pay the same salary that they might make in other parts of the world. But if she could build up the infrastructure and the resources and the quality, access to medicines, access to diagnostics, that would make them proud to come back and practice at a high level, then she could attract them back again. As part of that, ASCO has 2 international cancer core sites right now in Africa, which is where we have a strong partnership, mostly around training and education and quality. And those 2 sites, the Uganda Cancer Institute in Kampala, and most recently our Sub-Saharan Africa Regional Council selected the Black Lion Hospital in Addis. And so at a very strong institutional level, we're working on how do you build quality care? How do you define what quality is? How do you look for the barriers? And how do you build it up again? So that, I think, is one strategy for retention as well, and keeping people in country, and also bringing them back again.
Thank you, Julie. Let me go to Susan. You are an achiever, also working in Africa. You've had training. You have a number of exposure in outside the country. What do you think are the factors that help you to stay back in Africa and to work? And how do you think that we can galvanize some of what are other factors that you think we can use to attract our best and brightest to stay locally and provide service to a Native African? Susan.
Thank you very much, Letitia, for that very important question. Yeah, so it is a hard question. First of all, it's quite difficult to attract people into the oncology training. So I think the first thing we need to do is to actually get them while they are very young. While they are still in medical school, we need to start making them very interested. And when they do join the programs, we need to introduce them quickly to things that will keep them in the program, as well as to continue doing oncology even as they finish the program. And one thing that we can do that was mentioned in the previous session is get them to start doing research as early as possible within the program, so that by the time they are actually finishing the program, they are already, for lack of a better term, hooked into doing research in oncology and start to get grants, and hopefully that will get them tied to within the sub-Saharan area. In addition to that, as Julie mentioned, it is important for political will and governments to invest in resources, for instance, equipment and cancer medicines, because that will motivate them to actually practice what they are seeing in the books or in other research papers, rather than they are not able to practice what they're actually learning. So we need to actually put, in addition, investment on the ground, equipment, cancer medicines, etc. Thank you.
Dr. Alatishe.
Yeah, thank you, Ma.
Yes, because I'm in clinic, I just wanted to, and I missed the other one, I just wanted to add just a little bit to what she has said, and then I have to go back and see my patients. I think the most important thing that we have to do, and I acknowledge everyone that's been on the ground and has spoken, and you know that the only reason why people don't want to work in Africa is because there's no infrastructure for them to do their work. And so if there's anything I would like us to think about, it is really that governments must provide the hospitals and infrastructure. And if that doesn't happen, there's no amount of goodwill that good people want to have to treat patients on the continent that will work. And so since Afro, WHO, and World Bank are investing in infrastructure, both in the private sector and the public sector, I hope that we will come out of this meeting talking about infrastructure to allow people to run their own labs and to run their own research. And on that note, I'm going to leave and thank you all for doing this wonderful work.
Thank you, Fumi. Thank you for taking time out of your busy schedule to join us. Let's go back to our panelists. One of the things that have been discussed here, we have is mentorship and also making research attractive and profitable. It's definitely difficult for Africa, like Julie said, to pay a competitive salary compared to what is being paid outside Africa. But using research and using and mentoring some of this junior colleague, we may be able to return them. So I want, let's start with Nazima. What do you think? How do you think mentorship can help? And how do we make our research profitable? So I'll just go around each of you to just give some of your life experience on how you think providing mentors to junior ones and how your research has been attractive and profitable, how you think this has been helpful to attract people to stay back in Africa, please. Starting from Nazima, Julie, then Susan.
Thank you, Prof. I think that's a very important question. So I think it all goes down a lot to the will behind making this work, because if you want mentorship to act as an incentive for the young ones to stay, you need to have mentorship in place, first of all. And we do realize that in many of our institutions, we do not have a formal process for mentorship. So the first thing is to recognize the importance and to establish a mentorship system where young trainees or young researchers are linked with mentors who will take over the role of supporting them and helping them through their growth. But the young ones also need to see this mentorship working, and they need to see the success that comes from with their mentors to engage them further. So it comes down now to giving opportunities to these senior researchers and senior specialists in terms of publications, in terms of other incentives, which will make the younger ones feel more motivated towards continuing research and staying on in this role. I'll let the others continue with other points. Thank you.
I think, yeah, I mean, that's great. I totally agree with Nazima that having mentorship on the ground and role models to look up to who are in country is really critical. One of the things that we're talking to AORTIC about is we just launched a program in Latin America called our International Cancer Research Scholars Program. It's a year-long mentorship course in clinical research, and the majority of mentors are from Latin America. There is maybe a second mentor in some places from US, Canada, but the primary mentor is from Africa. And so this is a Latin America program, but we're looking to see if we could launch through our regional council in Sub-Saharan Africa and through AORTIC a similar program, because that pairing of a mentor who's in country, maybe at your institution, maybe not, is really critical so they can see that you can make it and you can be successful by staying and not leaving. So I'm looking forward to that. Mentorship is critical. I was part of when the Uganda Cancer Institute designed a formal training program in adult hematology and oncology, as opposed to the more traditional, ward rounds, and that's how you learned and all. It was, as Nazima points out, it was the senior faculty who were already in place who actually requested help in becoming formal faculty and formal mentors as part of the program. And so we spent a year working jointly with them in how to be a good mentor. So that's also teaching the senior level faculty how to be a good mentor and supporting them in that, and making sure their institutions are giving them the time and credit for doing that, because that is important as well.
Susan.
Thank you. I'll bring in a different aspect and with regards to mentorship. So I'll talk about peer-to-peer kind of mentorship. rather than the traditional, more superior mentorship to a junior fellow, for instance. What we've observed, at least at our institution, our trainees are able to relate better with peer mentors who are doing the same program in the North, for instance, in the United States. So someone who is in the third year residency, for instance, pairs up as a peer mentor to a trainee here in Zambia who's in their second or third year. And we find that they relate better. And then the mentors, the trainees still have mentors, those superior mentors, for instance, here in Zambia as a local mentor, African mentor, but a senior mentor also in the US, for instance. But we've found that that relationship between the peer mentors actually drives the interests of the trainees very much forward than just having the much older mentors. Thank you.
Thank you, everyone. It's been an exciting discussion. Let me just round up with this story that happened after my Monday is usually my operating day, and I had a long surgery. I did an hepatectomy, and I was just cracking joke with my junior colleague that I'm tired. I want you guys to come and take this kind of surgery for me. I want to run away. And I was shocked when two of them said, please just know that immediately you leave, wherever you go, tell them that you have so many that will follow you. And that brings a memory to me that, oh, some people are willing to stay back because some of us are making sacrifice to stay, and we are able to do some of this high-level surgery locally despite all the challenges. So my encouragement to the locals in the house is that beyond your imagination, you are making an impact to the junior colleagues, and staying back and working hard actually attract many to stay back. So let me hand over to the president of AORTIC, Dr. Miriam Mutebi. Thank you, our panelists, for the excellent contribution to this. I appreciate you.
Yeah. Thank you so much, Prof. Latishe, and really to the excellent panels and speakers. I think I really just want to take, I know we're way over time, but just to really thank all the speakers, all our partners, both new and old, and really showcasing and highlighting some of the key aspects that are essential, one, to not just galvanize research, but to retain and maintain a healthy, productive workforce that is impactful. I think one of the key messages that we've heard, whether it's through mentoring, whether it's through developing infrastructure, whether it's designing research, is really around collaboration. And it's really thinking through how do we get together all the stakeholders, how do we strengthen each other, how can we invest and use each other's strengths in order for us to improve and impact our patients. I think in the spirit of collaboration, you'll be happy to know that as AORTIC, it's business unusual. And we're now looking at more intentional work plans with all the partners on this call, and looking forward to seeing some definite concrete solutions around these key topics in the next coming year. Of course, we couldn't go without, putting a plug in for our biennial meeting in Tunisia 2025, where we're hoping we're going to be having not just a philosophical discussion, but real world evidence about how we have taken some of these concrete steps and sharing our success stories, or perhaps learning opportunities, but really ensuring that the conversation, whether it's with academic partners, whether it's through high-level advocacy in order to activate or motivate for change, or really at the grassroots level, where we're ensuring that communication occurs not just with each other as practitioners, but also with our communities. So to thank you all once again for your time and attention. I just want to give a special shout out to our President-elect, Dr. Zaltina Lorenzoni, who is on the call and was going to tell you a little more about our exciting approaches as we adopt to a 4-year work plan. We don't have time for that today, but it's just a teaser to stay tuned to the initiatives and efforts that we are working on with our partners, and looking forward to all the concrete steps and work plans that we develop. Thank you all for your time and attention. As Prof. Latisha says, we can all make an impact. So, let's continue the conversations and really think through how we can continue to impact at least one person each day. Enjoy the rest of the day, everyone, and thank you all for your attention.